New topic, placenta previa. Here we are going to learn the causes of third trimester bleeding, types of placenta previa, clinical features of placenta previa, its diagnosis and management of specifically central placenta previa. So, the causes of third trimester bleeding before we go into placenta previa specific. So, first one, placenta previa, second one, abruptio placenta, vasa previa, local causes and other causes. So, bleeding in third trimester is an obstetric emergency that can result from various things, and we have listed it already. So, first one, placenta previa. Placenta implants partially or completely over the internal os. Internal os, placenta previa. Best with a diagram, yeah. So, internal os over that leads to painless bright vaginal bleeding. Alright. Abruptio placenta, premature separation of normally implanted placenta characterized by painful vaginal bleeding with uterine tenderness. Now there is pain. So here you can see there is blood that is being accumulated because of premature separation of placenta from the uterine wall, and there is painful bleeding. So characterized by painful vaginal bleeding with uterine tenderness. Vasa previa, blood vessels over cross or run near the internal os leads to fetal distress due to blood loss. So same thing, but instead of placenta it is vasa. Vasa meaning this one, blood vessels. So vasa previa, even that will look for completion sake, even though it is obvious. So vasa previa, here you can see the blood vessels that are running just above the internal os. Local causes, we have cervical polyps, carcinomas, infections, trauma due to intercourse, and other causes include ruptured uterine scar, previous C-section, scar dehiscence, clotting disorders. So these are the causes of third trimester bleeding. Coming to types of placenta previa, classified based on degree of placental coverage over the internal os. That is type 1, type 2, type 3, type 4. Type 1, better to check out if there is an image, that would be better. Types of placenta previa. So first one is somewhere at the top, no, not this, is normal, this is somewhere here, and then it somehow almost covers, completely covers. Yeah, it's not 100%, but fine. Yeah, first one low lying, let's see. Yeah, so low lying you can see almost there, but not there yet. Placenta is primarily attached to the upper part of the upper uterine segment with only its lower margin extending into the lower segment. Only the lower margin extending into the lower segment. See, but mostly it's in the upper segment. Does not cover the internal os. Type 2, marginal placenta previa. Placenta reaches the margin of internal os but does not cover it. Margin, look at it, almost there. Type 3, incomplete or partial central placenta previa. The placenta partially covers the internal os when the cervix is closed but may not completely do so upon full dilation. So not on full dilation. So almost when it is closed but not on full dilation, that is type 3. Type 4, which is complete or central placenta previa, the placenta covers the internal os even when fully dilated. High risk of severe bleeding and maternal fetal complications. The placenta covers the internal os even when fully dilated, high risk of severe bleeding and maternal fetal complications. Yes, coming to clinical features. Sudden onset of painless vaginal bleeding in the second or third trimester. Makes sense. Recurrent bleeding episodes often increasing in severity. So bleeding increases in severity but it's not painful. Bright red blood indicating fresh maternal blood. No uterine tenderness or contractions unlike abruptio placenta wherein there is pain. Uterine tenderness is present here, contractions present here. High presenting fetal head with abnormal lie. So it is abnormal lie because the placenta is on the opposite side where it is supposed to be. So the fetal head would be on the opposite side. Fetal distress uncommon unless massive hemorrhage occurs. Placental adherence abnormalities, placenta accreta, increta, percreta may be suspected if bleeding is excessive. We have seen this already, but again better to take a look at what these mean. You can skip this section because we have already seen this, but better for revision because this particular placenta accreta topic hasn't been mentioned in the obstetric section. So, whenever we get a chance, we take a look at what this thing means. So, abnormal placental attachment where it invades beyond normal decidua basalis. So, it can be 3 accreta, increta, percreta directly into myometrium, invades into the myometrium through the uterus, possibly invading bladder or bowel. So, it is superficial attachment, partial thickness, full thickness. Risk factor, previous C-section, we have seen these already, but just for completion sake, not for completion sake, just for revision purposes, better to always learn something extra. Yeah, so this one is pass for what topic was it? It's placenta previa. Yes. So we are done with this. Next, coming to diagnosis. USG is the gold standard, trans-abdominal ultrasound initial screening and trans-vaginal ultrasound more accurate for placental localization and has 100% sensitivity, which is very nice. So, trans-abdominal, abdomen, vaginal. Doppler imaging used to assess placental vascularity and accreta spectrum disorders. Next, coming to MRI, useful in cases with suspected placenta accreta or percreta. Clinical findings: high floating fetal head, soft relaxed uterus, bright red vaginal bleeding. So, high floating head, soft relaxed uterus, not contracted tender type, bright red vaginal bleeding. And this is ChatGPT artifact because it was passed through this, right? So, because of that sometimes it comes up, it is fine, meaning the emoji. I want to remove it, but I don't want to remove it at the same time because it looks so nice, but it is fine. Speculum examination can be done in order to rule out local cervical causes, but digital examination is avoided to prevent placental separation and torrential hemorrhage. So, speculum examination is fine, but digital examination is avoided. Finally, coming to the treatment: immediate hospitalization, strict bed rest, intravenous fluid resuscitation with crystalloids, blood transfusion if severe bleeding, fetal monitoring with CTG, administer steroids, that is again betamethasone 12 mg IM, 2 doses 24 hours apart, if less than 34 weeks for lung maturation. Monitor maternal vitals every 15 minutes in cases of severe hemorrhage. Monitor maternal vitals every 15 minutes in cases of severe hemorrhage. Coming to expected management, less than 37 weeks. So, less than 37 weeks. Indicated if bleeding is mild and pregnancy is stable. Bleeding is mild and pregnancy is stable. Avoid vaginal examination. Repeat USG every 2 weeks to monitor placental migration. Iron supplementation is required for anemia. Tocolytics, nifedipine 10 mg oral as and when needed, can be used to prevent preterm labor. Finally, monitor maternal coagulation profile to prevent DIC. So, again for expectant management, indicated bleeding is mild and pregnancy is stable. Avoid vaginal examination. Repeat USG every 2 weeks to monitor placental migration. Iron supplementation to manage anemia. Tocolytics to prevent preterm labor. Coming to delivery planning, cesarean section is mandatory for central placenta previa. So, we know baby can't come out because the exit is blocked. So, you create a new exit. Timing: elective C-section at 37 to 38 weeks in stable cases, emergency C-section if active bleeding or fetal distress. Elective C-section 37-38 weeks in stable and emergency if active bleeding or fetal distress. Pass, yes. Placenta accreta, increta, percreta is suspected If it is suspected, preoperative planning includes blood availability and uterine artery embolization. Yes. In cases of severe hemorrhage, hysterectomy may be required. Finally, postpartum monitoring after the birth of the baby. Monitor for PPH, administer uterotonics cautiously, monitor for sepsis, DIC, anemia. This one, wait a second, uterotonics. Why? In placenta previa. This is something I personally did. The placenta partially or completely covers this. Oh, you don't want, sorry, yeah, sorry about that. This was a very basic, it was a lapse in logic. Very basic. You don't want contractions to happen, and because of this itself, you are doing C-section. You don't want the normal label to occur. So that is what is mentioned here. So you don't want uterotonics, and if you do it cautiously to prevent postpartum hemorrhage. Yes, that is what it means. Monitor for sepsis, DIC, anemia, neonatal intensive care. If preterm delivery is required, delayed cord clamping may be beneficial for neonatal hemoglobin levels. So this is the postpartum monitoring. So with this, we have gone through placenta previa in quite good detail. So in case you like this particular topic, the way I teach or how it is presented, you can like this video. In case you would like to more of such in case you would like to watch more of such videos, you can subscribe to this channel.